Well, hello everyone. I'm Dr. Thomas Shipley. I'm coming here from the Peoria, Arizona area. Peoria is a suburb of Phoenix. We're going to jump right in here, but before I do, just want to introduce my family. So, got 5 kids and a beautiful wife. This picture, shockingly enough, was taken right here in the desert. We went down into a little dry riverbed, found some greenery, and took some pictures. My youngest here, he's 5, and my twins just turned 15 and a half. They're going into their sophomore year of high school, and this week we've had the exciting time of teaching them how to drive. They just got their driver's permit, so you're lucky that I'm here with you tonight because there's been some close calls, I will tell you. All right, so let's see, going forward. Well, it looks like we'll have to click forward on the screen. There we go. Now we're moving forward. Okay. So a little bit about me. I was born in Northeast Tennessee. I'm not originally from the desert. So this is a little country road by my house in Tennessee, around where I grew up. Beautiful area of the country. So I do consider myself a Tennessee hillbilly. When I public speak, my accent usually comes out. So if you hear my accent, that's what that's all about. I did get a excuse me. I did get a business degree in '98, and so that's worked out pretty well for me for starting my own practice. This is a little bit of my background. I went to the University of Kentucky for dental school, graduated there in 2002. West Virginia University, Country Roads Take Me Home, West Virginia, 2005. That's when I graduated under Dr. Peter Nahn. For those of you praying people, we'll keep West Virginia in our prayers this week for all the flooding that they've had recently, and hopefully that state rebounds pretty quickly from the flooding that they've had. I'm going to have an opportunity to come out to West Virginia, I believe on July 29th. We're going to do a live presentation for the residents and some of the alumni there, and any other orthodontists who want to come to that meeting. So if you're in southern Pennsylvania or West Virginia, feel free to contact West Virginia University. I do have my own private practice, started up around 2005, 2006, just hung a shingle, got started on my own. I am ABO board certified. I'm a certified teacher of the 6 Elements orthodontic philosophy, which is kind of Larry Andrews' take on diagnosis and treatment planning. I am a certified orthodontics provider, which is how I got my start in accelerated orthodontic treatment, which made Propel a very easy and comforting leap. And I'm also an Invisalign Elite provider, which means I do over 100 cases a year of Invisalign. I'm on the clinical advisory board at Propel. I did get small number of shares of stock for being on their advisory board. Not sure how much that's worth, but I think that you should know that. And of course I do get paid an honorarium for doing things like this for this webinar tonight. I'm an adjunct professor at the Arizona School of Dentistry, so 2 times a month I go down and to Mesa, where their residency program is. I do a couple hours lecturing a couple times a month and then see patients with them in the clinic. So let's jump into some tooth movement. I'm going to really summarize the whole background around Propel this time. For those of you that feel like you need more of a robust tutorial on the biology, the science, the research, and the technique, I encourage you to go back and see some of my previous webinars or other people's webinars or read some of the publications. Really, I want to focus on a few more unique things tonight since we only have an hour in the webinar format. But to give you a basic summary, this is what tooth movement is all about. We put an orthodontic force on the tooth, and as we do that, we compress the PDL on the pressure side, and then we also get some tension or stretching of the PDL on the tension side. So as we compress that PDL, we get vascular constriction, and that causes a cytokine response, which triggers another cellular scheme of events which culminates in osteocytes turning into either osteoclasts or osteoblasts. So on the pressure side, where we get vascular constriction, we get osteoclasts come into the area to remove bone so that the tooth can then move in to the area in the direction where we're wanting to move it, and that's the frontal resorption side. On the opposite side, we then get tension, and that triggers a separate inflammatory type response, which again culminates in the conversion of osteocytes ultimately into osteoblasts to lay down new bone. So that's how teeth move, and if we want teeth to move faster, then we have to change the physiology around how this works, because we can't just push super hard on the tooth. If we just push harder on the tooth, we get something called undermining resorption. We get vascular obstruction, which we get a necrosis cell free zone hyalinization, which again is just going to ultimately cause the slowing down of the tooth movement. So if we want teeth to move faster, we just can't push harder. We've got to change the physiology of the way teeth, of that biological response. So there's a few ways in which we can do that. I've broken them down into a few different categories. One is pharmaceutical. These approaches have never really taken off in the orthodontic community for whatever reason. Prostaglandin injections can be painful. That's similar to a bee sting, so that's not going to work in our offices, at least not coming in 20 times throughout treatment to get 20 bee stings in their mouth. Electromagnetic stimulation is another theory that's not really taken off. But here's something that has got some traction in the orthodontic community. I think most of us are aware now of cyclic forces or vibration as an approach to move teeth. That's certainly a valid approach. It's got some pros and cons in it, as does micro-osteoperforations, or the MOPs from Propel. It's a different topic of which one is right for your patient, but in my opinion, the MOPs are pretty much the gold standard for most patients. There's laser and light stimuli. There's surgical stimuli such as Orthodontics, and then there's micro-osteoperforations, which is what we're going to be focusing on tonight. Micro-osteoperforations are, in this sense, with Propel, using a surgical grade stainless steel tip to go directly through the soft tissue and make something like a 2 millimeter dimple into the cortical plate, and that's called a micro-osteoperforation, or MOP. All of these have a common theme, a biological mechanism known as RAP. So what is RAP? RAP is regional acceleratory phenomenon. So we talked about that cascade of events that occurs when tooth movement is initiated. When we're talking about RAP, that whole process is accentuated. So we get more cytokines flooding the area, those chemical messengers, which cause that inflammatory type response that's going to culminate in the creation of osteoclasts and osteoblasts. So that is RAP, the regional acceleratory phenomenon. So what can we do in order to get more cytokines into the area to change the physiology of the bone so that the bone remodels faster around the teeth? So we have the cytokine response. Ultimately, we get osteocytes turning into pre-osteoblasts and osteoblasts on the tension side, but on the pressure side, pre-osteoclasts turning into osteoclasts. So our idea here is, if we create micro-osteoperforations in the bone or those MOPs, that's going to increase the amount of inflammation, which is going to increase the number of cytokines flooding into the area, which is going to increase the rate of bone remodeling and therefore increase the rate of the tooth movement. So there it is in a nutshell. That's what we're trying to achieve by doing the micro-osteoperforations. So again, the main factor that controls the rate of tooth movement is the rate of bone remodeling. Even when you magnify the force and type of tooth movement, your rate of movement is based on how the bone responds and remodels. I'm sorry about my little cough tonight. My allergies are a little bit bad this week in Arizona for some reason. I think it's a little bit dusty because it's been super dry. We've had a heat wave out here. I was in my pool, had to be in my pool this weekend or last weekend because it registered with the city at being 118 degrees, but my thermometer at the house had 122, which it hurt running to jump into the pool once we were in the pool just right. But for whatever reason, this dry dust is causing a little bit of cough. Sorry about that. Side note, so I apologize for that. So if we want to cause that iatrogenic traumatization to the bone, which is going to cause that increase in cytokines, there's a few ways in which we can do that. A surgical approach would be to do this approach similar to Orthodontics, where we do corticotomies into the bone. In this instance, a high-speed handpiece with a small round burr is used to make cortical incisions into the cortical plate of the bone. Now, we're not going all the way through the bone. We're just going a couple millimeters deep through the cortical plate. And then we're taking that same round burr and we're doing little dimples into the bone also. Again, just to iatrogenically traumatize that bone to try and get more cytokines into the area to get the teeth to move faster. So we can see here why this may not be good for the masses. Now, in fact, I've previously embraced this Orthodontics type procedure, had great success with it. I would still do it, but the problem is that it's not for everyone. This is great for patients who have no other options. A patient that if we don't do this procedure, the teeth just aren't going to move as far as we need them to move. And by the way, that's the most important part. We don't just do all this to get teeth to move faster, but we also do it to get teeth to move further, more stably, and more predictably. So by doing these procedures, not only is it more predictable, but we increase the range or the envelope of movement that we can get with the teeth. So in the Orthodontic circumstance, the patients in my office who have tended to elect to do this are the patients who, unless we do something like this, the teeth just aren't going to move where we want them to go. But most patients in my office, especially the class 1 moderate crowding cases, those patients are typically going to accept this as probably overkill. They're not going to go through this procedure just to cut a few months off treatment. And this is also expensive to do. It takes, they're uncomfortable for a week or so. So is there a better way? Well, here's the spectrum, and this is what we're going to talk about doing tonight is Propel. That's where we take a surgical grade stainless steel screw. We do what's called a MOP, or a micro-osteoperforation, go directly through the soft tissue to make a 2 millimeter dimple into the bone. And so this is what those dimples look like in the bone made with this screw tip. So we've got this rotation on this lateral. We want that to rotate. So we put the dimples into the bone, iatrogenically traumatize the bone, create that inflammatory process, flood with cytokines, teeth move faster and further. I think we got it, all right? But the key to this working as well as this is really the way that a screw works. All of us are familiar, or most of us are familiar with if we're doing carpentry and we've got a really nice piece of wood and we're getting ready to put a screw into the wood. Well, one of the things we're worried about by putting a screw into a piece of wood is we don't want the wood to fracture, because in a beautiful piece of furniture we'd hate to have that happen. So what do? We use a drill bit to drill a hole first, and that drill bit is going to remove wood out of the wood. And then when we go and put the screw in, we're not going to crack the wood. So what's the difference between the screw tip and the drill? Well, the drill bit is removing wood out of the wood. The screw is displacing the wood laterally. And so up in here, we're using a high-speed handpiece with a Orthodontics and a small round burr. So because we're removing bone from the area, we don't get the lateral displacement of the bone, and we affect a small little area. However, if we put a screw into the area, what happens is that we laterally displace the bone, and what we'll see happen, at least histologically, is we get micro stresses or micro fractures in the bone that radiate out to about 5 to 10 millimeters. And so if we want to affect the entire root of this tooth, we can overlap those areas, and those microfractures overlap, and then all of a sudden we've activated the entire root surface of the tooth by creating these microstresses or microfractures in the bone. So again, I want to emphasize it's not necessarily about the screw hole, that's just a small part of it. What's really helping us get the effect is the microstresses that radiate out to about 5 to 10 millimeters. And oh, by the way, it just doesn't go laterally. We also get that effect deep into the bone, so we get a sphere of influence about 5 to 10 millimeters. So the question then becomes, how many perforations do we have to do, and where do we want to do the perforations? And that's what I really want to spend tonight's webinar is talking about, is getting a little bit more detail with you guys about where, how many, and how do we place the micro perforations. Excuse me. So these are the accelerators, and these are what we're going to be using to do the micro-osteoperforations. Now, in today's world, this is the creme de la creme. The accelerator PT is, if you haven't purchased an accelerator yet, this is what you need to be purchasing, the automated driver. And you can ask your sales rep, Propel sales rep why, but I completely concur that this is the way to go. This is still great. The accelerator RT, I still have some of those in my office, and I still use them if, you know, I'm doing 4 or 5 cases in a day and this isn't quite getting through sterile fast enough. I'll still pull this out. It works great. But this is where I think you need to be moving to if you haven't already. And that's the device we're going to be talking about tonight, about where and how to do these micro-osteoperforations. But why do we want to do this? So let's go through some cases real quick about the amazing results that we can get with these micro-osteoperforations. Even though this works very well with braces also, I'm going to kind of focus my presentation tonight on Invisalign cases because of the ClinCheck software, it offers a very nice way for me to explain to you where and how to do the perforations. And what I hope is you can take from the Invisalign conversation that we're having tonight and use your big noggin that you all have as smart orthodontists, how to apply these same results to a normal braces case where we may not have ClinCheck software to help us out. And so we all know this. We got ClinCheck to figure out how to get the trays to move, but in our minds we're already using a ClinCheck type software in our own mind, and our own mind is even more powerful when we're doing these braces cases and we're envisioning how the teeth are going to move. So you can take these same principles and apply it to your braces cases. Or you can do something like a Sure Smile scan or an Anata model or something to where you can do, or a motion view, 3D model, any type of model on your braces case where you can simulate treatment, do a virtual treatment plan, and then you can use these same principles on that virtual treatment plan for your braces cases, or just use that powerful computer, the orthodontic mind that you have. So why would we even want to do this? Well, we want to do this because patients are asking for it. Patients are begging for it. Patients want it. Patients want to be done in 6 months. But as orthodontists, we don't want to finish them in 6 months unless we can give them the same high quality that we've always given. So there's this divide between patients wanting to finish faster and a specialist orthodontist who wants to deliver the best possible care. And Propel, MOPs, or micro-osteoperforation bridges that divide so that everyone can be happy. So let's look at some cases. We got some moderate lower crowding, rotated upper laterals. This has a class 2 component to it also, which is not shown in these pictures. But with 23 trays, instead of changing the aligners at the regular 14-day intervals, I changed them at 3 days per aligner, and the trays tracked better than they ever did at 2 weeks. And we finished this case in 4.5 months rather than in a year and a half, or a year to a year and a half for this case. 43 trays on top. The reason why we had 43 trays is we were also doing class 2 elastics getting distalization. You can see we managed these rotations quite nicely. 3 days per tray, and we finished this case in 4.5 months. A little bit more difficult case, you can see a significant midline shift, a deep bite. We're going to open this deep bite, fix the midline shift, The teeth fit a little bit better with the midline off a little bit, so I designed that into my ClinCheck. We got the lateral, the canine down here that's going to be hard to track. As the Invisalign plastic pushes this tooth buccally, the tray kind of wants to slip over this lingual surface, so that's kind of difficult. So we're going to do Propel to help us on this case, and this is the final result that we got with the Propel. Able to open the deep bite, get the midline somewhat corrected. Great position of the canine here, taking care of this rotated lateral, this rotated canine. So very nice results. Instead of 1.5 years for this case, we finished this case in 4.5 months with 35 aligners. So I had this patient changing their aligners every 3 days, and we were able to finish the case in just 4.5 months. So this is very, very powerful. Bridges that gap. We're able to give the patients quality specialist care that we've always given. We're just able to give it more rapidly, which is they want to be done in under 6 months. So we can still give them great care and finish in a time that's more reasonable. And not only that, look at this nice finish with an Invisalign case. So maybe this will make our clear aligners work better for us and allow us to treat more patients with clear aligners, which is also what the patients are wanting. So Propel is very, very powerful in helping us bridge the gap between what the patients want and also what we feel obligated to give as specialists and orthodontists. Another challenging Invisalign case, look at these laterals. Very difficult for the plastic to grip onto these laterals and get them where we need to be. So the MOPs are going to give us predictability, rotate those laterals, and in this case, a very nice result. 36 aligners, 3 days per aligner. We finished this case in 6 months. She did Propel at month 3. So she was wearing her trays 2 weeks per aligner until we did Propel at month 3 when she decided she wanted to finish early because of a wedding. And so we said, how about doing Propel? 3 months later we were done, and she was the maid of honor in time for the nice pictures. Here we've got a diastema filled with composite. Why do that when we can close that space in 3 or 4 months? So here we've removed some of the composite. She was reluctant to let me remove it all because she was afraid of the way it looked. After I took this picture, I showed her with the tray in that the light reflects off the plastic of the tray and you can't see it. So after I took this picture, she allowed me to remove the rest of this composite the same day. So from this picture to this picture, that was exactly 8 weeks. So we closed all this space plus some more and got a really nice occlusion. We did some IPR on the bottom too. 19 Invisalign trays, 3 days per tray. We finished this case in just 8 weeks. Anterior crossbite. So and a little bit of diastema there. We're going to do IPR down on the lower. We're going to tip those upper teeth, these canine and lateral out, bring these back. 3 days per aligner with this case as well, 27 aligners. We finished this case in 4 months. Again, the micro-osteoperforation is proving time and time again to be very powerful in allowing us to deliver what the patients want. A little bit easier case, going to line up those lower incisors textbook every time with Propel and Invisalign. This will line up really nice. This is going to be 14 Invisalign trays, 8 weeks. Again, this presentation right now, just giving a quick summary of how powerful Propel is. I've presented these cases several times in more detail. Some of them have articles written about them. So if you want more details on these cases, I encourage you to go back to some of the previous webinars. We want to get to a very specific topic tonight. So again, that tricky lateral, that lower right lateral, very nice finish with Invisalign and Propel. 29 aligners, 3 days per aligner. This case finished in just 5 months. So how can we deliver this to as many patients as possible, because this is what they're coming into my office asking for, begging for what patients are referring other patients into my office now. How do we do this? Another case here, we've got some relapsed second bicuspid extraction cases not treated in my office. So, but I'm going to treat this. We're going to propel mesial and distal to the 6s, move those molars forward, propel lower 2 to 2, take care of that crowding. 24 trays. This was one of my staff, so of course they never do what I tell them. I told her to change her aligners every 3 days. She changed them every 2, and so she went from before and after here in just 8 weeks. Deep bite, sigmoid-shaped arches. We're going to do propel more teeth here, deep bite. We're going to open that up, align that lower crowding. This was 21 aligners, 3 days per aligner. We were able to finish this case in just 3 months. One of my favorite cases here, treated with Invisalign and Propel. Significant deep bite, significant lower crowding. Really difficult for these canines and these laterals with Invisalign. These narrow sigmoid-shaped arches, so we want to expand these out. Look at how this dips in and these teeth just disappear behind the canines. Going to create the dark triangles in the smile. So we want to broaden that out for the patient. Propel can help us do that with Invisalign more predictably. So here we are when we're done, we got a very nice expansion, able to open that bite, align those lower anteriors, the upper anteriors. Patient absolutely ecstatic, very powerful, but check this out. 35 aligners for this case, 4 months, no refinement, patient very, very pleased. So, wow, powerful. How do we do this? Where, when, and how do we place the micro-osteoperforations? Well, it's not rocket science. We want teeth to move, and for teeth to move, we need the roots to move. And for roots to move, if we want them to move faster, we've got to change the physiology around the bone. And we know that we get around these micro-osteoperforations, we get about a 5 to 10 millimeter sphere of influence that affects the root of the teeth. Changes the physiology so that the osteoclasts and osteoblasts come into the area faster, teeth move faster. So really what we need to do is just learn how to get these MOPs to overlap in a way to affect as much of the root as possible for the teeth that need to move. Well, for most patients, that's really just going to require a buccal access, 2 to 3 micro-osteoperforations between the teeth in order to activate the teeth. Now, if the teeth roots are straight up and down, we can do it in a linear fashion, 2 to 3 MOPs. If the roots are divergent, we can maybe do a triangular shape. Typically, we don't have to go onto the palate because, again, from the buccal, that's going to radiate in to the bone and approximate the palatal or lingual surfaces of the teeth also. Really the only time we need to get onto the palate is when we are exposing canines. Well, if we want to affect the root of the tooth to optimize tooth movement, what's the best place to activate the tooth? Well, I would propose to you that the most important place to activate the root of the tooth with a MOP is going to be around the center of resistance of the tooth. And so, you know, I teach the 6 elements of oral facial harmony, that diagnostic and orthodontic philosophy program. And one thing that I learned from Larry Andrews is that these centers of rotation of the teeth are related to each other. They're in a very similar position in the dental arch for each tooth. And what I learned from him is that where the mucogingival junction is, where the attached tissue meets the mucosa for most patients, at that point the teeth, the centers of rotation of the teeth generally coincide with that mucogingival junction. Well, Larry Andrews calls that line passing through the mucogingival junction of all the teeth, or just above it, the wall or ridge. You can see that in some of the orthodontic literature. But that wall or ridge is very similar to the mucogingival junction, but not always, because sometimes patient may have recession or something like that. But in the normal patient, the mucogingival junction approaches or approximates the center of resistance of the tooth. And this is the area where I really want to activate the tooth with the micro-osteoperforations. So here's that mucogingival junction, or the Waller ridge, and if we were to draw a line in an arch through the centers of rotation of all the roots of the teeth, the Waller ridge or the mucogingival junction would approximate those centers of resistances for all the teeth. So if we want to find the mucogingival junction in the normal average patient, it's going to be right in this area right here. So if we're only going to do one micro-osteoperforation, we would want that micro-osteoperforation to be right in this area so that we activate the center of resistance of the tooth. Well, if I'm only going to do one, am I going to do it above the line or below the line or just on the line? Well, I don't want to necessarily do it below the line if I'm only going to do one, because that's in the mucosa. It's a lot easier to go through the attached tissue than through the mucosa. So if I have a choice and I'm only going to do one, I'm going to put it just above that mucogingival junction into the attached gingiva to activate the center of resistance of the tooth. But why just do just one? Because the tooth is longer than 5 to 10 millimeters, and I want to activate as much of the root as possible. So if I can, I'm going to try and get 2 micro-osteoperforations on the teeth that I want to activate. Now, I don't have to activate all the teeth, just the ones that need to move significantly. So if I'm only going to do one, it's going to be something like this. But if I'm going to do 2, I'm going to put one above the mucogingival junction and one below. So now I spread these out 5 to 10 millimeters. Now these areas are going to overlap, and we're going to activate much more of the root, with most of the activation being around the center of resistance of the tooth. So let's say I want to move all the teeth in this arch, which is atypical. I would do 2 micro-osteoperforations between each of the roots of the teeth in this case. And now with the contour angle on the new electric driver, we can even get further back here if we want. So atypical to need to activate all of the teeth, but if I were, this is very similar to what it would look like. Now, when we're down into the mucosa, most places in the mucosa, especially on the upper or in the anterior, we don't have much problems with the mucosa. But in some areas, because the tissue is so loose, sometimes we need to keep an eye on that tissue because it can start to wrap around the screw. Typically, all we have to do is just stop, kind of catch ourselves before the tissue keeps winding around the screw, kind of put a finger on the tissue to stretch it out, and then continue on with our perforation. But be careful, because in some areas, especially down here in the lower mucosa, sometimes the tissue can wrap around there. So sometimes in the posterior region in the lower mandible, sometimes I'll just put the 1 perforation here rather than the 2 to help prevent that tissue winding, especially if the tissue is really thin. But typically what I will do is I'll give it a try down in this area, but if the tissue looks like it's going to be winding around to be a problem, then I'll just go back and put my 1 right at just above the mucogingival junction in those areas. And that typically will be enough, but if it's easy to get to, I'm going to say get 2. Well, what about a tooth with a really long root like this canine? Well, for a canine, I'm going to try, especially one that's got a significant rotation, I'm going to try and get a little bit more root activation. So on my long canines that have a real problem, I might try and get 3 micro-osteoperforations. So 2 to 3 micro-perforations is plenty in the areas for the teeth we want to activate. If possible, 1 above the mucogingival junction, 1 below. If we're worried about the tissue or the mucosa winding around, we might just go to 1 micro-osteoperforations, which should also be enough. Doesn't cost you any more to do a second one, but if you think it's going to wind around, just do the 1 just above the mucogingival junction. So that's how many to place, but on what teeth do we do it? Well, can I plan it using the ClinCheck? Well, absolutely you can for your Invisalign cases. That's a perfect way to plan out how to do your micro-osteoperforation. So I'm going to go through how to use ClinCheck to help you plan out a micro-osteoperforation Propel case. But remember, you're not limited to the ClinChecks. You can do this same thing for braces cases. You just have to use that computer of your brain to figure out where the teeth are moving, but apply the same principles that we're going to use ClinCheck to talk about today. Or you can also use some diagnostic software such as Motion Views, diagnostic software, treatment simulation software, or SureSmile treatment simulation software, Anatomodels, anything like that. You can apply these same principles. So I bet most of you didn't know that there's a secret Propel Here page that comes with your Invisalign software. I bet you didn't know that. Well, let me show you where to find it. Okay, so if we're looking here at the ClinCheck software, all you have to go is to the treatment tab. Now this is using ClinCheck Web. You can get to this same information. Let me escape out of this for a minute and show you on a ClinCheck. You can get to this same information. Oh, sorry, let's not go through the ClinCheck. Let's go through software. So you can get to the treatment overview here. You can choose either ClinCheck Web or you can use ClinCheck. Basically, you want to get to the printouts that come with your aligners, okay? But on your software, all you need to do is to make it to that printout. Let's go back into the presentation. So that's going to be on your treatment tab, and then we want to get to these pages, and guess what? They really want you to see them, so they also send it in the Invisalign box. So if you can't find it on the computer, it comes in your box. Isn't that great? Well, you guys have just caught on to me. It doesn't actually say Propel here, but these are little cheat sheets that you can use to let you know where to propel. So this particular sheet is going to be page 3 of 3 on that treatment tab, and you scroll down. And what this is going to show you is the moderate and advanced teeth. So blue teeth are going to be moderate difficult movements. The black teeth are going to be advanced movements that may require some difficulty. A lot of times there's no challenging movement. Sometimes, depending on how difficult of a case you accept for Invisalign, and with Propel you can accept more difficult cases, but with a difficult case there's going to be more. So like things like roof movement, intrusions, big labial and distal movements, bodily movement, those might be moderate or advanced teeth. So this is where compliance issues can cause the aligners to go off track, or this is where you might just have to give the tooth a little bit of oomph with a mop instead of just treating it just with normal Invisalign. So in this particular patient, tooth number 12, or the upper left 4, is a moderate difficult tooth. So I would propose to you that you might consider, again this is on page 3, that you might consider putting a couple of mops, mesial and distal, to these teeth. So the blue and black teeth, usually you want to go ahead and do the mops on those teeth. So that's a little cheat sheet for you at a little baseline to get started. So what I like to do is, if I'm planning this when I chair side, is I'll actually take this sheet out of the Invisalign box and start marking it on the sheet so that I can keep track. And then I go back and look at the ClinCheck software. So now I'll come back, and this is the wrong view, but I'll look at that tooth on the software, scroll back and forth with the slider, see how that tooth is moving, make sure that it makes sense to do the perforations there, and then chair side I'll just make an X here, make an X here on that sheet, and I'll just go back and forth and use this to plan out my micro-osteoperforations. Or if I'm pre-planning this and the patient's not in the office, then I'll get this online just like I showed you, print it out, but then as I'm going back and forth looking at the ClinCheck, I'll just mark the areas where I want to do the mops. So another cheat sheet is page 2 of this of the treatment tab and of these printouts. Now, here I'm looking at where are we doing the IPR. Now, I don't advocate doing IPR every time on all, sorry, I don't advocate doing MOPs on all the teeth that we're doing IPR on no matter what. All I'm saying is the areas where we're doing IPR, probably a red flag that a MOP may be needed in that area. So what we can do is look at the areas where we're having the IPR, determine why the IPR is needed, and deciding if Propel will help to aid in that tooth movement. So again, we're not doing Propel because we're doing IPR, but we want to look at all these red flags. Why am I doing IPR here? Is this going to be a difficult movement that's going to have trouble tracking at 3, 5, or 7 days a tray, whatever interval we use? If so, we can come back and mark those areas for micro-osteoperforations. Also on this page, we can look at the attachments. The attachments are also red flags for areas where we may want to do micro-osteoperforations. So let's think about this. Some of these teeth are going to be, and I don't know if this is the right terminology, but some of these attachments I call primary attachments, and some of these attachments I call secondary attachments. What do I mean by that? Well, let's look at this bicuspid here. We've got coupling attachments on this bicuspid, probably to give root torque to this tooth. Well, if I'm putting coupling attachments and doing primary movement on this tooth, then that's going to be an area where I have a coupling attachment that you betcha that I'm probably going to want to do micro-osteoperforations on this tooth. So I'm going to put an X here, put an X here, put one here, put one here, 2 mesial and distal of this first bicuspid because we've got coupling attachments. Well, what about these canines? Well, I got to go back and look at the ClinCheck software and the simulation, but let's think about this. These attachments here are probably here as secondary attachments just as anchorage. So don't need to propel these teeth necessarily because these are just providing anchorage for this coupling. So again, not all the attachments need MOPs, but it's just in a way to where you can get a red flag to see maybe I need to propel that tooth. Let's move forward. Another area is if I'm looking right here, hey look, I've got cutouts for some class 3 elastics on this case. So if I'm running class 3 elastics, that triggers my mind, how do I want to do micro-osteoperforations or propel to get the elastics to look better? And we'll show that a better way in a case to come. So where else do I treat? Well, I can use the ClinCheck software to try and find rate-limiting teeth. So so let's look for a rate limiter tooth. This tooth right here is going to end up being our rate limiter. Also, other cases may require more comprehensive treatment like arch expansion or midline shift. Those cases can be done with Invisalign and Propel too, but let's look at the ClinCheck software to determine where we need to propel. So we can go to ClinCheck or ClinCheck Web. This is a great way using the grid to determine how far a tooth is moving to find that rate limiting tooth. So one thing that we can do when we go to this grid is, let me back out of this presentation, go to an actual ClinCheck software program. So we go to the grid and look what I can do. Now if I hit control and my left mouse button, I can zoom in and out. Okay, so let's say I'm trying to determine how much space I have to close these diaspis. Well, I can hold down the shift button and my left mouse button and I can move this around. So let's say I want to see how far the incisal edges are moving, or I want to see how far that diastema has to close. Well, I can use the shift left click button to drag this over to this darker line, and I can see, well, that's about 1.5 millimeters of space I got to close. Or how much is the incisal edge closing? So I can move that up and I can see, okay, the incisal edge moved here up 0.5 millimeter because I moved the grid using the shift key to get to the incisal edge. Then I scroll through the bar to see how much it moved. Now the best use of the ClinCheck software to determining where we do propel is using this, because this gives our big brain of ours, our mind, the opportunity to actually see where and how the teeth are moving, and that's going to help us determine where to propel. So for instance, on this case, moving back and forth, I see a upper 2 to 2. I'm using a lot of root torque on this case, so I want to probably propel upper 2 to 2. So that's how I can use that scroll bar in the grid to help me out. Let's get back into our presentation. Here we go. Okay, superimposition is another great tool that we can use. So we hit that superimposition key, and it's a bit of a trick to use that superimposition tool. So when I use the superimposition, I can take off the overcorrection trays, I can take off the IPR, I can take off the attachments, all those things, but I've got a superimposition key up here. And so this button moves teeth white, this button moves teeth blue, and so I can use this to see which one best represents the movement of the teeth. So here I can see what's moving this way, here I can see what's moving this way. So let's get to a better example. Let's do the mandibular only. Let me see how these teeth are moving. So here we can see that we're moving the lower anterior teeth forward in this case, proclining those forward with class 2 elastics. So that superimposition tool can show you, hey, yeah, we're proclining those a lot. This is all by plan. We're moving these forward with class 2 elastics. Wow, I better propel lower 6 to 6 on this case. So you can use the superimposition tool to help you out. Let's go back into our presentation. So here we can see different types of movement just by looking at the occlusal view, mesial and distal buccal lingual rotation, torque, tip, occlusal view. So again, what we're looking here is for those rate limiting movements. Now, so what they're doing here is, if we were to scroll through this ClinCheck, this is a rate limiting tooth. So they're going to move this tooth lingually back into position, and they're going to use 18 trays in order to move that tooth back. Well, these teeth have to move somewhat less over 18 trays. So let's talk about this tiny rotation that this distal edge of this central has to do. It just has to rotate in a little bit. Well, it doesn't need 18 trays in order to do that, but this is the rate limiting tooth, so that tooth is going to tip in over 18 trays. Well, we don't need to switch the trays every 2 weeks to move that. We can switch the trays out every 5 or 7 days without doing propel, and that one would be just fine because they've got that little movement spread out over 18 teeth. However, this is a rate limiting one, so we better propel this rate limiting tooth and then look at the other teeth if there's other rate limiting ones. Like this canine may be difficult to do, so we probably want to perforate mesial and distal of this lateral and mesial and distal of this canine looking at that view. Let's go to the next slide. I already showed you on the actual ClinCheck of a different patient how to slide this back and forth real quickly. That's the best use of this slider tool to let you see how much the teeth have to move, especially if you have superimposition involved. From this side view, you can see buccal and facial views, intrusion, extrusion. Again, look at that superimposition plus the grid, slide it back and forth, find those rate limiting teeth, and here we can see just these tiny movements that we're doing over 18 trays. We don't need to propel these tiny movements, and we certainly don't need to only switch the trays every 14 days in order to get these tiny movements. So we don't have to propel these teeth for it to keep up at 5 or 7 days a tray if we just propel here. Now here we're also propelling this mesial surface of this canine, which has to move in quite a bit. So here I'm just showing just these perforations on that one lateral incisor. Well, what about the bottom on this case? Well, it's a little bit more complicated. Let's go back and forth on this. Similar to what we would do with the slider tooth. Well, we're getting quite a bit of buccal expansion on these teeth. So since we're getting so much buccal expansion, let's do 1 to 2 perforations between those teeth, because it's going to take a good 15 trays in order to get that rate limiting movement of that buccal expansion. So we want to make sure we mop those teeth. Down here we've got quite a bit of movement on this bicuspid. It's coming out buccally quite a bit, so we're going to mop those teeth. And where this canine is rotating out, that's going to have an effect on the distal too. So again, we can use this ClinCheck, these tools, these tricks, to use our piece of paper and just write down where the rate limiting teeth are, where the difficult movements are, and do our perforations in these areas. These are the same thought processes we need to go through with our braces cases in determining where we need to do the micro-osteoperforations. After doing several cases like this, planning them out, it'll probably only take you 2 to 3 minutes to put down the MOPs that you need to do to plan these cases out, and then the assistants are going to use their topical to numb these areas up for you, and 3 to 5 minutes of treatment time is all it's going to take to do those few perforations on those teeth. We don't have to perforate the entire mouth, just those rate limiting teeth that we use the ClinCheck software to determine. So in this case, we can do something. I would probably use 3-day intervals, but you could do 5 or 7-day intervals. In this example, if we use 5-day intervals, 6 aligners in the first visit. Second visit, we're going to deliver aligners 7 through 12. Visit 3, 13 through 18 at 5 days per aligner. So on 4 appointments or 90 days, we're going to have this case finished at 5-day intervals. We might need a minor refinement and push it into the 4 or 5 month case. So let's do some more cases real quickly with this, with just a few minutes. Now, this is actually not going to be a Propel case for me. I'm going to use this as an example of why I would want to do Propel now. So we've got congenitally missing lateral incisors. The patient determined she wants lateral incisor implants. So we got to move these teeth back, create space for lateral incisor implants, take care of these crazy rotations and crowding on the bottom. Guess what? She's not willing to do braces. She only wants to do Invisalign. And this is before I started Propel. So you can see these canines have to go back quite a ways. Propel would really help me here, but I didn't use it to get this bodily movement of the roots. So here I am when I'm done with this case. You can see we were able to open up enough space for the implants to be placed, took care of the lower crowding, and perfectly placed implants but ready to be restored. You can see that using Invisalign we were able to distalize the canines, bodily move those roots, get them upright so we had room for the implants. On the x-ray the implants kind of blurred, but rest assured they're in a good position, and she's had these implants restored, and now she's got a fabulous looking result. She didn't want to do any surgery or anything for the gummy smile. So this was a 3-year Invisalign case with 2 refinements. What's the problem for this 3 years? Well, she had Pontics in her Invisalign trays, and every time she had to go out to eat socially, she had to take her teeth out. Well, that's too bad for the patient. That's a poor quality of life. Can we shorten this down? What if we could do this in like 9 months instead of 3 years so the patient doesn't have to go without those teeth for as long? Can we use Propel in order to help us? So this is another patient, again, congenitally missing laterals, the canine's in that position, crazy crowding down here on the bottom. Guess what? He wants to do Invisalign also. So let's give it a try, and let's do it with Propel and see if we can do it even faster. But where do we do the perforations in such a difficult case? Well, look at these roots. We've got to really bodily move those canines and central so that we can have enough room for those roots. We don't want them to be convergent. We've got to bodily move the roots so that we have room for the implants. So let's use our grid and our templates to help us out. Look at this. We can see some things going on right here with our superimposition tool. We're proclining these teeth right here. We're distalizing all these teeth. Look at the significant amount of distalization we have to do on all these teeth. So I've got bad news for you. This is probably going to be an upper 6 to 6 case. So that might take us 5 or 10 minutes to get that upper 6 to 6 completed to distalize those teeth and these teeth. Let's look at the bottom. On the bottom, not so significant movement. Here we can see just a little bit of expansion, but we're doing that Little bit of expansion, what? About half a millimeter here, but it's over 34 trays, so I don't need to propel back in this area. But look at this lower crowding, the rotated canines that we can see with the superimposition, and look at this movement here, this expansion of the 4. So in this case, I'm maybe thinking 4 to 4. But let's use our cheat sheets to help us out further. Well, let's look at the moderate and difficult movements. Well, you betcha on these teeth right here, I'm going to want to do propel on these teeth. And it gives you a reason why down here. So let's look at the lower right 4. Lower right 4, it's a blue tooth. That tooth has to extrude 0.8 millimeters. The range for that is 0.5 to 0.1, so that's a moderate movement, so we need to propel that tooth. And this canine, wow, that's a difficult movement. What are we doing on that lower right canine? It's a rotation. Anything greater than 55 degrees, and this one's 58, going to be a significant advanced movement. You betcha I want to propel this tooth, and it's got that big long root, so I'm going to consider doing 3 micro-osteoperforations. So on my sheet, right there chair side or planning at my desk with ClinCheck, I'm going to just mark 3 perforations, mesial to this canine, 2 around the other moderate movements. What about the IPR sheet? Again, red flags. What about these coupling attachments? Red flags. Well, I already know from looking at the bottom that all of these teeth have to distalize quite a bit, but I didn't really see a need for lots of movement on the 5. Got 34 trays to close that half a millimeter space. I'm just not going to do propel around that 5. So on the bottom, I'm going to end up doing lower 4 to 4. And then I'm going to add on the upper for all of those teeth because we had to do lots of distalization. So not just one thing is going to say yes, propel here, don't propel here. We're going to put all this information together to put a final sheet, and that's where I'm going to propel for this patient. So here we are the day of the micro-osteoperforations. Here we are 3 weeks later. Everything's healed up just fine. 4 months post-propel, we can see that we're starting to open up those spaces. The teeth are distalizing. These are coming forward. And you can see those difficult canines starting to unravel just 4 months after propel. The patient's changing their aligners every 3 days. That's what I do. You can do 5 or 7, whatever suits you better. Because we were reclining those teeth, the plastic was starting to come off the incisal edge of these teeth, so I decided to put little hooks to do bootstraps to hold those teeth down into the aligners, but the case is complete in 9 months rather than in 3 years. So this patient is only going to have to go 9 months with those Pontics coming in and out at dinner time rather than the 3 years like the other patient. Look at this canine, that difficult crowding on the lower, perfectly aligned in just 9 months. What a powerful tool propel can be. We just need to use the tools that we have to determine where we're going to do the perforations. So now we've got plenty of room for those implants to be placed. This patient just finished up recently, about 4 months ago, so the implants have been placed. They're actually covered up in this picture. The implants are there in this picture, and I think in a week or 2 he's going to go in to get his final restorations. Look how nicely these lower teeth lined up for him in just 9 months. Look at the root parallelism. We bodily move these teeth by putting the MOPs mesial and distal, one above, one or below the mucogingival junction or the center of resistance of those roots to help them go bodily move in a quicker fashion. Let's try one last case before we finish up. So here's a class 3 case, 13-year-old that most patients wouldn't attack with Invisalign, but we're going to give it a try, and we're going to use our ClinCheck software to help us determine where to do this. So we can see he's a full step molar class 3, edge to edge bite, lower crowding, peg laterals, all the things that we don't like to see for a class 3 case. Now he's already been treated with a phase 1, not by me. The upper incisors are already proclined, and I want to limit the amount of proclination of the upper incisors. So we don't have much time, so let's go through this real quick. This is our ClinCheck software, class 3 elastics. We're going to distalize these lower teeth. So we've got class 3 elastics running here, do an IPR on the bottom, we're going to retrocline the lower teeth, distalize these, and then at the end we're going to extrude those teeth. So let's go back and play that all the way through. So I'm going to show that one more time. We're going to use the IPR, class 3 elastics, to move these teeth distally, retrocline the lower. Then we're going to use the Invisalign to extrude, upper true to close that bite. So let's play that again now that we can see. Class 3 elastics, IPR, distalize the lower, retrocline the lower, extrude the upper 2 to 2. Well, we've got class 3 elastics in this case. How can we use Propel in order to get maximum effect out of our elastics? Well, in this case, I already said I don't want the upper incisors to procline much more. Well, the side effect of class 3 elastics is the upper teeth are going to want to procline, these are going to want to retrocline. Well, what if I use Propel to develop a differential anchorage system so that I get less proclination of the upper teeth, more reclination of the lower? Well, what if I propel back here but not up here? Well, if I propel these areas, I'm going to get more effect of the class 3 elastics on the bottom. If I don't propel up here, these teeth are going to then become anchorage units so that these teeth, front teeth, don't get moved forward and procline more. So these teeth, by not propelling them, become anchorage teeth. These teeth are going to move faster because of the propel. So when I'm looking at the ClinCheck, I'm going to do everything that I can to avoid doing perforations in this upper posterior region, and I'm probably going to put perforations in this lower posterior region so that I can get the distalization that I need. Well, these posterior teeth are acting as anchorage units, so I might want to propel up here to get some extrusion. So real quickly, let's look at our cheat sheets that come with the Invisalign box. So here, let's look at the 4 and 5, moderate and advanced teeth. You betcha I'm going to want to put 2 perforations, mesial and distal, of each of those teeth. The torquing ridges, the class 3 elastic cutouts, all clues, all red flags. Why do I need those? Are those areas where I want to do Propel? Well, let's look at the ClinCheck software. Going to use the superimposition tool. All right, so I've enlarged this. I've used the grid to line the incisal edges up original with a line, so now I can move. See that those teeth are extruding 1.5 millimeters for the centrals, a good maybe 1.5 millimeters for the laterals. Difficult movement for plastic trays to get, so you betcha I'm going to want to put micro-osteoperforations for those upper anterior teeth to help aid in that extrusion. But I want to avoid it in the posterior teeth because I want these teeth to be anchorage units for my class 3 elastics. Here on the sides, I can see the distalization that I've got to get here on the posterior teeth. So you betcha I'm going to want to propel back in this area because that's a lot of distalization in the back for those lower teeth. So propel, 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 propel. What about on the top? Well, up here we're showing some mesialization of the teeth, but remember I'm wanting to not do propel here because I want to actually not get too much movement here. So I don't want to get too much movement from the elastics. So with me adding the elastics on, and these asking with anchorage movements, I'll probably get this mesialization without propel, and I don't want any more than that, so I'm not going to propel these teeth. So again, just because we see a big movement doesn't necessarily mean we have to do propel there. Think about our anchorage and our mechanics with that big orthodontic super brain of yours and put all the pieces together to determine where to do the perforations. This is probably the most advanced type of case that you're going to treatment plan using Propel. So if you can do this one, you can do any one, but I think you guys have the clues. That first case that I showed you, 4 perforations on the top, a few on the bottom, no big deal. This is really advanced, but you can do this too by putting together the tools, all these tools that we have on the ClinCheck software to make this difficult case work. Again, you can see all this movement that we've got on the bottom. Absolutely, I want to propel these teeth for these rotations, so I'm going to end up being lower 6 to 6 on those teeth. I can use the IPR sheet to look for red flags. Because of the ClinCheck software, I know why I'm doing IPR on all these spaces. So you bet I'm going to go ahead and propel where all of those IPR spots are and more. I'm even going to go distal to the 7s to get that distalization. The new contra angle driver from Propel makes this very, very easy to accomplish that. Looks like I should have put a couple more dots for the presentation here. So lower 6 to 6, 7 to 7 on this case, upper 2 to 2, and let's see what the results are going to be. So this is 12 weeks into treatment, 8 weeks post-Propel, and we can see how wonderfully the trays are tracking. I'm having the patient change their aligners every 3 days instead of every 14 days. If you're not comfortable with that, you can go to 5, you can go to 7, but hey, monitor it closely. My opinion is I get better results at 3 days a tray than I do at 5 or 7, but that's a conversation for another day. But do what you feel comfortable with. So look how much great results we've got. We're only halfway through treatment, and halfway through treatment is only 12 weeks. So now let's look at this. 18 weeks of treatment, 4.5 months, we're completely done. $49.50 pay in full, 34 aligners. This patient came in for 5 treatment visits, almost $1,000 a visit. We've got everything accomplished here except for the bonding of the peg laterals. The patient is absolutely ecstatic, so guess what? His sister's going to do the same thing, same type of treatment with her Invisalign. Great results. This is the power of Propel. So that's where I'm going to end the presentation tonight. We'll take some questions. I hope that this gives you an idea of when, where, and how to place the micro-osteoperforations. Again, go back and look at some previous webinars in order to get more information about the scientific basis of Propel, a few other tidbits about how to do the procedure, how to get anesthesia, all those things. Big conversations that you've now got plenty of webinars stocked up that you can talk to your Invisalign rep and see how to view those to become an absolute expert at this, but it doesn't take much to be an expert. It's really easy to accomplish. We just got to go through, bridge that gap between what the patients want and the quality care that we want to give them. So I'm going to end the presentation with that, and I will now open the floor for questions. So those of you that want to ask questions, all you've got to do is type in your question in the question pane, and I will just go through and start going through those questions, and some of these are already built up. And if you asked them earlier, I'm just now looking at them for the first time. So let's see, Carolina says, good afternoon, I'd like to ask Dr. Shipley if I'm going to use TADs near the area I'm supposed to use Propel. How far must the procedure of propelling from the TAD to be safe that I'm not interfering in the anchorage? I mean, for example, in a case of intrusion of a superior extruded molar that I'm pretending to use a TAD in the buccal side and other at the palate, can I propel this molar? Well, I would suggest what I typically do is if I'm going to place a TAD in the area, I typically don't do Propel in that area. I'll probably skip to the next contact area or even skip one contact past that. Here's my rationale. When we're placing a TAD, we're not just doing a 2 millimeter perforation like we're doing with Propel. With Propel, we're only going 2 millimeters into the cortical plate. With a TAD, we're going deep into the bone. We're going 7, 9, 11 millimeters deep into the bone. So the range at which those micro stresses spread out from the TAD are going to be a little bit greater than it would be for the Propel if we're putting a TAD device in and leaving it there. Now we can't use a TAD to do Propel because it's going to break, it's going to dull too quick, it's going to fall down the patient's throat because it's not attached to the driver. It's been shown that TADs don't work very well for doing a Propel, but when you place that TAD, you're going to get a cytokine response to that TAD. Unfortunately, that's why so many TADs end up falling out. So what I would say to you is no, you don't need to propel directly around where you place that TAD. Skip a contact area or two and do that area, and that's my rationale for that area. Okay, Nelson says, hi, how often do you use propel in a single case? That's a great question. Again, so much background on that question. I spend 10, 15 minutes on other webinars and in live presentations at least talking about that. But let me give you the basic rundown. Propel recommends propelling doing the procedure a second time every 4 or 5 months, every 3 or 4 months. Personally, I repeat the procedure every 5 or 6 months, but here's the thing. In most of my Invisalign propel cases, I'm done in under 6 months. So for most of my cases, we only have to do the procedure once. For some cases where we do a refinement, let's say we're in month 6 or 7, we're doing a refinement, or in a braces case where we're doing some detailing at month 6 or 7, then we might come in and re-propel some teeth. But remember, the second time we do the procedure, it's much, much easier because we don't have to do as many teeth, because in these cases we're usually detailing. So the number of teeth we have to propel much, much smaller. So usually only one set of perforations per case. If we get into months 6 to 9, I probably do a second set of perforations. It's going to be fewer teeth, only the ones that we have to detail for whatever reason. Again, I do it every 5 or 6 months. The company Propel recommends every 3 or 4 months. Jason says, I may have missed this, but how long does the propel effect last? How often do you need to re-propel? Looks like you guys asked at the same time. So, yep, I'm looking at the time. You both typed it in at the same time. So I hope I answered that question previously. I think the effect lasts for about 5 or 6 months. Propel recommends redoing the procedure every 3 or 4. I typically do it every 5 or 6 months, which means most cases I only have to do it once. Do you charge extra per propel tip, and how much cost? So this is Jose asking now. So let's say so I charge per each time that I perforate each patient. Typically, this is another big long conversation that we talk about in previous webinars. I charge $200 each time we do propel, regardless of the number of perforations in that visit. For each visit I do the procedure, I only charge $200. If I do a second visit, absolutely, I charge another $200 to do that. If the patient, for whatever reason, doesn't want to pay the $200, I don't let that be a limiting factor. I'm perfectly happy to give the procedure away, because look at the slide that we're looking at, $1,000 a visit, that's a lot of productivity. I don't want to lose that productivity just because the patient doesn't want to do $200, but typically we charge $200. Jose again asks, what if you do multiple procedures on the same patient? Do you charge them for more tips? I think I just answered that question also. Okay, that's my last question that I have. So I don't think that I will have any more questions. If you've got a last-minute question, start typing furiously right now. So I'm going to end the webinar right there. You guys have been a great audience. Hey, this has been a high turnout tonight. 50% turnout for a webinar. That's absolutely astounding. So thank you all for being here. I wish you success. I know we didn't even come close to covering all the topics with Propel. Go back and look at those other webinars. You're going to bridge the gap. The patients are going to love you. You're going to get more referrals. You're going to make take-home satchels full of money. The patients will pay you better than any other patients in your practice. So thank you so much for visiting tonight. Again, I'm going to be giving you another webinar next month. We'll tackle some more difficult cases, and hopefully you'll find that interesting to you also. Thank you very much, and that's where I'll end the conversation.